My name is Morgan Culver, and I'm a clinical pharmacy specialist in hematology and oncology here at the Massey Cancer Center. And once a month, I hold a session with patients and their caregivers discussing the potential toxicities of chemotherapy and how to manage them. So that's some of what we'll discuss today. So to understand how chemotherapy works, it's really important to understand how cancer occurs. And for normal, healthy patients, what happens is that your cells are programmed to die at a certain point, and then your body makes new ones to replace it. But in patients who have cancer, one of two problems happens. Either those cells don't die when they should, so they accumulate over time and you have too many, or cells are made when they're not needed and you get an excess of cells. So in patients with cancer, it's one of those two problems. Either they're not dying when they should or they're making more than they're supposed to. So chemotherapy medications, or our traditional chemotherapy medications, work by focusing on those cells that are produced when they should not be produced. So cells that are dividing at a really rapid rate. And that's important to remember because chemotherapy traditionally cannot tell the difference between a normal healthy cell and a cancer cell. It just looks for any cell that's dividing at a very rapid rate, and we call those cytotoxic, meaning killing cells. And so that's where a lot of the toxicities comes from, is the inability for the chemotherapy to tell the difference. We put chemotherapy agents into a couple of different buckets or groups based off of how they work. So a lot of them work on different parts of the cell and can therefore cause different types of toxicities. You may see patients who get multiple chemotherapy agents at once, and the reason for that is to try to trick the cancer cells by giving them drugs that work in different ways. But those patients may experience more complications as a result. So there's a lot of different types of chemotherapy, and like I mentioned, they're grouped based off of how they work. Our more traditional chemotherapy agents would be things like cyclophosphamide or doxorubicin, whereas our newer chemotherapy agents actually can discriminate between cells that are normal healthy cells and cells that are cancer cells. We call those targeted therapies because they target a certain part of the cancer cell. Those medications often end in mAb, such as rituximab, or MIB, like imatinib or dasatinib. The complications or the side effects of those medications are very different, and we don't really consider those our traditional chemotherapy drugs. We kind of put those in separate groups. We're also finding that we're able to give chemotherapy in a lot of different ways. Usually we picture a patient getting a medication through their IV, and while that still may be the case, it's not always the way that we have to give chemotherapy anymore. A lot of our medications are able to be taken as a pill at home, and so there's certainly different considerations for those. Sometimes it can be given as an injection under the skin, similar to the way that people take insulin. Sometimes it can be given into a space within the spine when patients get a spinal tap or a lumbar puncture, although that's rare. That is a way that we can give chemotherapy. So we're able to use a lot of different routes of administration for chemotherapy, not just through an IV. So there are a lot of common toxicities that are the same regardless of which chemotherapeutic agent a patient receives. And again, this is because the chemotherapy can't tell the difference between the normal cells and the cancer cells. So normal healthy cells that divide very rapidly are the cells of the GI tract, including the mouth, the whole way through the intestines and in the stomach. So those become subject to damage. That's why patients often develop nausea and diarrhea. The cells of the hair and nails tend to produce very quickly, so that's why patients lose their hair and they can develop some nail changes. And then the blood cells also divide very rapidly. White blood cells, red blood cells, and platelets all produce at a faster rate than a lot of other cells. So those can all become decreased when patients receive chemotherapy, and that's probably our biggest medical concern with those patients. The nausea and vomiting can be caused by a couple of different reasons. One is just from the irritation itself. So the cells in the gastrointestinal tract divide very quickly, so they become subject to damage, and that irritation can cause people to become nauseous. But the other has to do with a section of the brain that actually looks for different types of poisons. We call this the chemoreceptor trigger zone. Normally, your brain is protected from anything in the blood so that if you got a virus or a bacteria, it couldn't affect your brain and cause further harm. And we call that the blood-brain barrier. But there are gaps in that barrier that are constantly sampling the blood to look for different toxins or poisons. If those poisons are detected, it tells your stomach to reverse everything and get rid of it as quickly as possible. The fastest way to do that is to vomit. So we call it the chemoreceptor trigger zone. And in that area of the brain, those little receptors will actually detect any chemotherapy as a poison. So preventing and treating nausea and vomiting is one of the biggest things that we focus on when we're developing a regimen for a patient or a chemotherapy regimen. We want to make sure that we do everything we can to prevent nausea and vomiting from occurring. And we do a pretty good job at that. And when we select the appropriate medications and we administer them appropriately, we're able to prevent vomiting about 90% of the time. Our mechanisms for managing nausea and vomiting once it develops aren't quite as good. So prevention is definitely key. Most patients that receive chemotherapy will be given medications about an hour ahead of their chemotherapy regimen in an effort to prevent any nausea and vomiting from occurring. We use medications like steroids, so a lot of patients might get something like dexamethasone. We use other medications like ondansetron or Zofran, and all of these medications work at trying to prevent that process of being initiated, where the brain sends the signal to the stomach. We try to turn that signal off, and that's what those medications do. We have other medications that we can offer to the patient or that the patient can have access to at home, which will allow them to treat their nausea should it develop despite our preventative strategies. Those medications tend to not be as effective as the preventative strategies, but they may still work, particularly if they're taken early on. So we always encourage our patients to take them as soon as they feel nauseous, not to wait until they're actively vomiting, because they may not be as effective in that instance. Even though we offer preventative strategies and we offer treatment for nausea and vomiting, something else to consider is that there may be other causes of a patient's nausea and vomiting not related to the chemotherapy itself. It could be their underlying malignancy that causes them to be nauseous, depending on where that malignancy is located. Other medications can cause nausea and vomiting, like a lot of our pain medications. Acid reflux can actually contribute to nausea and vomiting, so for patients experiencing heartburn, they should let their provider know so that can be managed as well. And then other things like constipation can cause nausea and vomiting. So if the patient's not getting relief with the treatments that we are providing, it's important for them to notify their provider of any other symptoms so that we can try to address those as well. So mucositis is another complication of chemotherapy that develops as a result of chemotherapy damaging the cells within the mouth. It typically presents as an irritation or an ulcer. If you think of if you have ever bit the inside of your cheek and you get a little bit of an ulcer there, that's commonly how it starts, and can really range in severity from just a very small, tiny spot to really affecting the entire mouth the whole way through the gastrointestinal tract. And so this is something that not every chemotherapy patient experiences. It's more common with some chemotherapeutic agents than others, and is more common at higher doses, but is something that we like to educate patients about because we do have ways to manage it if we need to. So to manage mucositis, we can use some pain management strategies. So we have different mouthwashes that we can compound in our pharmacy that contain numbing agents and anti-inflammatories, just to try to decrease that irritation or to numb the mouth so that the patient can have a little bit of relief, which will allow them to still eat and drink as much as possible while they're at home. We discourage patients from using any mouthwash that contains alcohol, like Listerine. Not only will it burn and be uncomfortable, but it can really increase that irritation and could actually make it worse. We have other strategies that we provide to patients to allow them to still take in adequate calories or enough calories without causing further pain and damage. So we really want patients to consider the texture of their food, nothing crunchy or hard, to consider the acidity of their food, so no citrusy things, no tomatoes, and the spices that they're adding, avoiding salty things. So sticking to bland, soft foods like scrambled eggs, oatmeal, bananas, those types of foods are often comfortable for the patients to eat and provide a lot of calories. Ice cream is always a popular favorite. Anything that can be put in a crock pot that can be made really soft are also good options. Other management strategies, sometimes we do have to rely on stronger pain medications. So things like morphine or oxycodone sometimes have to be used just to allow the patient to still be able to eat and drink. But sometimes patients even need to be admitted to the hospital if it's severe enough so that we can provide them with the calories and the hydration that's required for them. Chemotherapy can cause hair and nail changes because the hair and the nails, those cells typically do divide at a pretty rapid rate, so they become subject to damage. Not every patient loses their hair, and not every patient has damage to their nails. Sometimes people think that their nails will fall out. That's typically not the case. It's more a change to the color or texture of the nails, and it's not permanent. As their nails grow, any of those changes will grow out. For patients that do lose their hair, it typically takes about 3 weeks for them to start to notice the hair loss, and it doesn't happen overnight. It'll be a gradual process where they may notice when they get up in the morning there's more hair on their pillow. After a shower, there's more hair around the drain, and so over time that process will occur. It's not painful, but it can be irritating. For females who have ever had their hair in a ponytail that's too tight for too long and they take it out, and sometimes it causes that little bit of irritation or it's uncomfortable. That's how some patients describe it as they're losing their hair. So it's not typically painful, but it can also be itchy. So we can have patients who decide that they just want to shave their head to hasten up that process and not have to worry about the gradual hair loss. While medically it's not concerning, I think emotionally it can be one of the more disconcerting complications for patients, because it does change their appearance and it changes the way that they see themselves and other people see them. It kind of has that stigma that now everybody can see them as a cancer patient, whereas some of these other things that medically we're concerned about, other people can't see. So we do have a lot of things that we can offer to our patients here at Massey that can help them deal with some of those changes. We have a wig salon here at Massey that can help patients, can offer them a wig to manage their hair loss, can help them to improve their appearance. They can choose a totally different hairstyle if they want to try something new, but they'll also help with things like tying scarves and head wraps, just things to keep them warm, because especially in the winter time, that's something that can be uncomfortable for the patients, is just losing all of that heat through their head. One of the most medically concerning adverse effects of chemotherapy is the effect on the blood counts. So there's 3 types of blood cells in the body that we pay particularly close attention to. The white blood cells which fight infection, the hemoglobin or the red blood cells that circulate oxygen throughout the body, and then our platelets, which help our blood to clot. So all of those cells divide at a relatively rapid rate, some of them faster than others. But because they divide relatively quickly, they will be subject to damage from chemotherapy and they can decline. For some patients, we just see a minor drop and it doesn't become problematic. But for other patients, we can see a pretty significant decrease in those blood counts to the point that they may be at risk for complications. So if their white blood cells decline, they're at risk for infection, and that's something that we have to pay very close attention to. For patients who have a drop in their red blood cells, they may notice that they're fatigued and tired because they're not circulating oxygen like they used to. And then for patients who have low platelets, their blood can't clot as well as it normally would, and so they would be at an increased risk for bleeding and bruising. One of the terms that you'll hear being discussed with cancer patients is the term neutropenia. Neutropenia means a low neutrophil count. Neutrophils are one type of white blood cell, but we pay particularly close attention to those in patients getting chemotherapy for 2 reasons. One reason is because they're the most subject to damage from chemotherapy. They divide the fastest of all of the white blood cells and thereby are more likely to be damaged. But the other reason is the neutrophils are the first responders to any invaders. So bacterial infections that people are commonly exposed to, it's the neutrophils that fight against those. If those neutrophils become low after being damaged from chemotherapy, patients are at a much higher risk of getting a bacterial infection. So you'll hear this term neutropenia. Neutropenia means a neutrophil count that's less than 1,000. And that's something that we monitor with our blood work regularly. For some patients, if they do become neutropenic or have that low neutrophil count, like I said, they're at a higher risk of infection. So we have them monitor their temperature at home. If they think they're getting a fever, we want them to check their temperature. If their temperature is above 100.4, we want them to call in and let us know. We assume that it's an infection until we can prove that it's not, because sometimes the only symptom that they'll have is that fever. We may give them antibiotics to try to manage that until we can prove that it's not a bacterial infection. We may have them come into the hospital and get IV antibiotics if they need to. Kind of depends on the situation and how sick the patient is, but it's something that we do take very seriously. One of the other things that we can offer our patients is the ability to prevent that neutrophil count from getting too low. So we know with certain chemotherapy agents, we anticipate that that neutrophil count will be low for quite an extended period of time. And we can offer them medications like filgrastim or pegfilgrastim, also known as Neupogen and Neulasta. Those medications will prevent the neutrophil count from being too low for too long and essentially decreasing the risk that that patient will get an infection. Not everybody needs those medications, but with certain chemotherapy regimens, that is something that we offer to them here in clinic, given as a quick injection to try to prevent those infections from occurring. So anemia is the term that we use to describe low red blood cells. We measure that by looking at the hemoglobin, which is part of the red blood cell that helps to carry oxygen. So when patients have a low red blood cell count or a low hemoglobin, they may experience symptoms of that oxygen not circulating very well. So if they're not getting enough oxygen to their brain, they may feel dizzy, they may feel really tired. They may notice that when they're up moving around, they feel like their heart is racing because their heart is attempting to try to circulate the blood faster and make sure that enough oxygen is getting moved around through their body. Unfortunately, there's no medication that we can really provide that's safe for patients to help boost up that red blood cell level. So instead, what we often rely upon are blood transfusions if the patient's really symptomatic or if we find that that hemoglobin number is really low. Again, not everybody needs a blood transfusion, but we really rely on the patient to let us know how they're feeling to determine if that's necessary. The thrombocytopenia is the term that we use to describe a low platelet count, remembering that platelets are those cells that help our blood to clot. So if those cells become low in number, the patient may notice that they bruise more easily than normal. They may notice some bleeding. Perhaps after they brush their teeth, they have some bleeding in their gums or nosebleeds. All of those things are kind of expected and we don't get too alarmed. We do get alarmed though if the patient notices that they have blood in their urine or stool. That is not normal. So we again rely on the patients to let us know if they're experiencing those symptoms. We do monitor their platelet count, and in some patients they may actually need a transfusion of just platelets to help boost that number up to a safe level so that they're not at a high risk of bleeding. But there's really no medication that we can provide to help get the platelet count up to a safer level. So there are some precautions that patients should keep in mind and their caregivers should keep in mind when a patient's undergoing chemotherapy. This becomes even more of an issue for those patients who take chemotherapy as a pill at home because they're not coming into clinic as often, they're not being seen regularly by a provider. So those patients, we really need them to call and let us know if they're having any changes or any problems because they're not being directly observed on a regular basis. But some other considerations to think about when the patient's at home would be good hand hygiene. It's really important for the patient and their caregiver to wash their hands regularly to prevent any exposure to infection, but also after using the restroom, because we know that chemotherapy on average would probably stay in the body for about 48 hours, and that can vary greatly depending on the drugs that they're getting, but 48 hours is a safe number. And we know that within that 48 hours, the patient may still be excreting the chemotherapy that they've received. So if they use the restroom and they share that restroom with somebody else within the house, there's the potential that there's chemotherapy remnants within that restroom. And so washing hands afterwards becomes very important. We also encourage patients to, when they're flushing the toilet, to close the lid so that none of those chemotherapy particles get aerosolized within the bathroom. If the patient were to have any bodily fluids within the house, that if they were to vomit or if they were to be incontinent, if their caregiver is going to clean that up, they should really wear gloves, especially within that 48-hour period of time, to make sure that the caregiver is not being exposed to any of the chemotherapy. And then if the linens were to become soiled, we always recommend that they wash them separately from their other laundry, making sure to use hot water, again, just to try to decrease any exposure to the caregiver to that chemotherapy that the patient received. So for patients who are undergoing chemotherapy, I think it's really important for them to keep a couple of things in mind. One is that they should be vigilant. they know themselves and they know their bodies better than any provider. And so if something is new or different for them, we really encourage them to let us know. Sometimes this means complaining and whining and just kind of having to suck it up and make that phone call, because that gives us a lot of information. And sometimes it's just relieving the patient and giving them a little bit of peace of mind to say, yes, this is expected, and helping them work through it and manage it. But sometimes we can say that's actually a very serious consequence that may seem like a very small thing at the time, and we know can become more severe. So we want patients to really be vigilant and let us know if things are changing, and give us a call if they have any questions. The other piece of advice that I always offer is we certainly want patients to be their own health advocates and to be as knowledgeable as possible about their medications and their disease, and there's some great references to help them do that. But at the same time, we don't want them to just Google it, because there's so much information out there on the internet. Some of it's very accurate and very appropriate and helpful, but other information may not be. And so we always ask the patients to, if they want to learn more, to let us know that so that we can direct them to some valid, helpful resources to get the information that they want. And then finally, as a pharmacist, I would have to say not to pop a pill before you ask somebody first. Chemotherapy can have a lot of drug interactions, and that can either cause excessive toxicity, making those side effects even worse, but can also potentially limit the effectiveness of the chemotherapy that the patient's receiving, which we don't want either. So if the patient's considering taking a medication, even if it's an herbal supplement or Tylenol or a multivitamin, something over the counter, it's always good to ask the pharmacist or their physician if that's safe with the chemotherapy that they're receiving. There's two great resources that I often recommend for patients undergoing chemotherapy. One is if they want to learn just more about their disease, and that's using the American Cancer Society's website. Going to the American Cancer Society's website, there's a drop-down menu where they can choose the disease state that they want to learn more about, and it puts all of the information in patient-friendly terms. It explains the tests that would be done to work up that disease state. It explains to them what a CT scan would feel like, what an MRI would be like if they had to experience that, what a bone marrow biopsy would be like, so they kind of know what to expect with the testing. It also explains how their disease state is staged and what the treatment would be for each of those stages in terms that most patients would be able to understand. If the patient wants to learn more about their chemotherapy medications, a great website is ChemoCare. Going to ChemoCare, there's two sections of the website. One is geared towards the chemotherapy specifically. They click on the medication that they want to learn more about, and it tells them things like the most common side effects, the most severe side effects, when their counts will be at their lowest, and when they expect their blood counts to get back up to a normal level. It also gives lists of advice for when to call the provider, so things that they could experience at home that would be severe enough to warrant a phone call. The second section of that website is actually geared towards managing adverse effects. So if the patient's experiencing mucositis, they click on mucositis. It can give them mouthwashes that they can make at home to try to make it a little bit more comfortable. It can give them dietary tips, and they have a nice section for all of the adverse effects that patients are most likely to experience. So I think those two websites really provide valid information and helpful information, and those are the ones that we use most commonly.